Hello student, welcome to the lecture on government and private health services, and after this lecture we will be able to learn the following objectives. Understand the government health services, discuss about per capita income and utilization of government hospital, understand the opinion about inpatient services, explain complaints and allegation against government hospitals, discuss about private health services. Let's start with the introduction. Socioeconomic inequalities in health status have been defined as differences in the prevalence or incidence of health problems between individual people of higher or lower socioeconomic status. Inequalities which are socially unjust are considered to be inequitable. International Society for Equity in Health defines equity as the absence of systematic and potentially remediable differences in one or more aspects of health across population subgroups defined socially, economically, demographically or geographically. Two dimensions of health inequities have been quoted on literature, that is horizontal and vertical. Vertical equity highlights the needs to treat unequals differently, that is riches should pay a higher proportion of their income for assessing healthcare services compared to poor. Another dimension of redistribution is added to this twofold typology, which ascertains who gets the benefits of public subsidy and to what extent. Barring a few socialist countries like India, where the state is the sole provider of medical care, most of the developed and developing world largely has a mixed provisioning of services. The relative roles of public and private sectors in healthcare in developing countries have changed considerably over time. Although the state has played a central role in providing medical care in India, private interests were never curbed, and as a result they have grown over the years. The private medical sector is vested with certain characteristics. The practitioners are like their counterparts in the public sector, trained in Western type, hospital-based, urban-oriented medical care system. Community health is perhaps the weakest and most neglected part of their curriculum. A license to practice is issued to them soon after their training. Once they start practice, the phase of their education comes to an end and they are completely free to pursue their vocation. Let us now discuss government health services. Though government health services are available freely to the poor, they are not fully used by them. Many factors are responsible for the underutilization of the government hospital. Majority of the people use government hospital for inpatient care as they can escape from the huge hospital bill levied by the private hospitals. The analysis of curative care revealed that for outpatient care, only very few are using the government hospitals because they have to borrow entire medicine from private sources. This deals with the utilization of government hospital causes for non-utilization of government hospital and knowledge about various departments in the government hospital and the complaints about government hospital. The SES class with the number of households who utilize government hospitals health centers during the last 3 years. It shows that 43.3% households in urban and 88.8% households in slum utilize government hospital. From the table, it can be seen that 100% of the very low class SES5 and 85% of the low class SES4 in urban areas use government hospital in the last 3 years. For the urban slum, this was 97.5% and 96.8% respectively for SES5 and SES4. Though the upper classes used private hospital, it was very meager, and it is to be noted that nobody in the upper class SES used government hospital.
How government solved the healthcare crisis. Medical insurance that worked until government fixed it. By Dr. Rod Long. Today, we are constantly being told the United States faces a healthcare crisis. Medical costs are too high and health insurance is out of reach of the poor. The cause of this crisis is never made very clear, but the cure is obvious to nearly everybody. Government must step in and solve the problem. 80 years ago, Americans were also told that their nation was facing a healthcare crisis. Then, however, the complaint was that medical costs were too low and that health insurance was too accessible. But in that era too, government stepped forward to solve the problem, and boy did it solve it. In the late 19th and early 20th centuries, one of the primary sources of healthcare and health insurance for the working poor in Britain, Australia, and the United States was the Fraternal Society. Fraternal societies, called Friendly Societies in Britain and Australia, were voluntary mutual aid associations. Their descendants survive among us today in the form of the Shriners, Elks, Masons, and similar organizations. But these no longer play the central role in American life they formerly did. As recently as 1920, over 1/4 of all adult Americans were members of fraternal societies. The figure was still higher in Britain and Australia. Fraternal societies were particularly popular among blacks and immigrants. Indeed, Teddy Roosevelt's famous attack on hyphenated Americans was motivated in part by hostility to the immigrants' fraternal societies. He and other progressives sought to Americanize immigrants by making them dependent for support on the democratic state, rather than on their own independent ethnic communities. The principle behind the fraternal societies was simple. A group of working-class people would form an association, or join a local branch or lodge of an existing association, and pay monthly fees into the association's treasury. Individual members would then be able to draw on the pooled resources in times of need. The fraternal societies thus operated as a form of self-help insurance company. Turn-of-the-century America offered a dizzying array of fraternal societies to choose from. Some catered to a particular ethnic or religious group, others did not. Many offered entertainment and social life to their members or engaged in community service. Some fraternal societies were run entirely by and for women. The kinds of services from which members could choose often varied as well, though the most commonly offered were life insurance, disability insurance, and lodge practice. Lodge practice refers to an arrangement, reminiscent of today's HMOs, whereby a particular society or lodge would contract with a doctor to provide medical care to its members. The doctor received a regular salary on a retainer basis, rather than charging per item. Members would pay a yearly fee and then call on the doctor's services as needed. If medical services were found unsatisfactory, the doctor would be penalized and the contract might not be renewed. Large members reportedly enjoyed the degree of customer control this system afforded them, and the tendency to overuse the physician's services was kept in check by the Fraternal Society's own self-policing. Large members who wanted to avoid future increases in premiums were motivated to make sure that their fellow members were not abusing the system. Most remarkable was the low cost at which these medical services were provided. At the turn of the century, the average cost of large practice to an individual member was between $1 and $2 a year. A day's wage would pay for a year's worth of medical care. By contrast, the average cost of medical service on the regular market was between $1 and $2 per visit. Yet licensed physicians, particularly those who did not come from big-name medical schools, competed vigorously for large contracts, perhaps because of the security they offered, and this competition continued to keep costs low. The response of the medical establishment, both in America and in Britain, was one of outrage. The institution of large practice was denounced in harsh language and apocalyptic tones. Such low fees, many doctors charged, were bankrupting the medical profession. Moreover, many saw it as a blow to the dignity of the profession that trained physicians should be eagerly bidding for the chance to serve as the hirelings of lower-class tradesmen. It was particularly detestable that such uneducated and socially inferior people should be permitted to set fees for the physician's services, or to sit in judgment on professionals to determine whether their services had been satisfactory. The government, they demanded, must do something. And so it did. In Britain, the state put an end to the evil of large practice by bringing healthcare under political control. Physicians' fees would now be determined by panels of trained professionals, i.e., the physicians themselves, rather than by ignorant patients. State-financed medical care edged out large practice. Those who were being forced to pay taxes for free health care, whether they wanted it or not, had little incentive to pay extra for health care through the fraternal societies, rather than using the government care they had already paid for. In America, it took longer for the nation's healthcare system to be socialized, so the medical establishment had to achieve its ends more indirectly, but the essential result was the same. Medical societies like the AMA imposed sanctions on doctors who dared to sign large practice contracts. This might have been less effective if such medical societies had not had access to government power, but in fact, thanks to government grants of privilege, they controlled the medical licensure procedure, thus ensuring that those in their disfavor would be denied the right to practice medicine. Such licensure laws also offered the medical establishment a less overt way of combating large practice. It was during this period that the AMA made the requirements for medical licensure far more strict than they had previously been. The reason, they claimed, was to raise the quality of medical care. But the result was that the number of physicians fell, competition dwindled, and medical fees rose. The vast pool of physicians bidding for large practice contracts had been abolished. As with any market good, artificial restriction on supply created high prices, a particular hardship for the working class members of fraternal societies. The final death blow to large practice was struck by the fraternal societies themselves. The National Fraternal Congress, attempting like the AMA to reap the benefits of cartelization, lobbied for laws decreeing a legal minimum on the rates fraternal societies could charge. Unfortunately for the lobbyists, the lobbying effort was successful. The unintended consequence was that the minimum rates laws made the services of fraternal societies no longer competitive. Thus, the National Fraternal Congress's lobbying efforts, rather than creating a formidable mutual aid cartel, simply destroyed the fraternal society's market niche, and with it, the opportunity for low-cost health care for the working poor. Why do we have a crisis in healthcare costs today? because government solved the last one.
Let us now discuss another topic: per capita income and utilization of government hospital. Though the impact of SES on utilization of government health services is analyzed, the linkage of per capita income, though it is a constituent in measuring the SES of household on the utilization of government hospitals, health centers, is analyzed separately. It reveals that as per capita income slab increases, the percentage of households who utilize government hospital services decreases, and it is common for both urban and slum households. The decline in utilization of government health services as per capita income increases is much deeper in the per capita income slab 501,750 in the case of slum compared to urban, where the decline is not so deeper. This indicates that even certain better income groups are utilizing government hospital for getting either medical reimbursement facility or for recording the treatment undergone under the government doctors for availing medical relief. Thus, per capita income and utilization of government hospital is moving in the opposite direction. Let us now discuss opinion about inpatient services. It can be seen that with regard to the inpatient services received from the government hospital, 92% of the slum respondents and 78% of the urban respondents were totally dissatisfied, indicating the poor and dismal performance of government hospital. The test and treatment offered in hospital was very bad. Accessibility of a doctor is a must for the patient, while staying in the hospital is impatient. The accessibility of the doctor is the vital factor which prompts a patient to stay in the hospital. But according to many respondents, reveals that the accessibility is very poor. The inpatient services of government hospitals are inhuman. Picture of the government doctors whose education government had incurred crores of rupees from the public exchequer. The most pitiable aspect of these deeds is that it is the low class and very low class household SES4 and SESS in the society who suffer a lot due to the sad state of affairs of government hospitals. These sections find it difficult to approach private healthcare centers quite often, whereas the richer section always prefers private health centers alone. Complaints and allegations against government hospital. In order to get vivid picture about the service condition of the government hospitals, the lack of proper checkup of patient due to the carelessness of the doctor is causing severe medical problems to the patient and in certain times even death. Lack of medical equipment is also causing severe problem for the patient. Though government hospital is meant for the poor and vulnerable in the society, there is no medical equipment properly functioning in most of the hospital. For X-ray, ECG, etc., patients have to go outside, even for blood tests, sputum tests, urine tests, etc. Private sector is the only resort. Even if certain equipments were there, most of the time they will be in out of order or under damage, and the authorities concerned would not take initiative to repair it due to pressure from outside private agencies which render these services. Similarly, the poor nursing care, favoritism, indifferent doctors' behavior, etc. are also categorized as complaints against government hospital. Most of the nurses behave arrogantly and will not show any sympathy, and if the patient raises any doubts about the medicine, they irritate on them. In the informal chat with the respondents and household members of the study area, it is realized few more complaints against government hospitals and doctors. Even if medicines were available in government hospital, doctors in duty prescribe medicines to outside. Similarly, for X-ray, ECG, ultrasound scanning, etc., this prescribed to outside private agencies and will not take interest to repair the existing equipment or install new one. As the doctors are raising good amount as commission from these private agencies, they try their level best to continue the statu quo of government hospital for years. Since the houses of upper middle, upper class and lower middle class households were maintained clean and neat, the hospital environment looked unclean to them when compared to the cleanliness of their houses. On the other hand, the dwellings of the slum households and urban poor were not at all maintained properly, and neatness was not a problem to them. In the slum, one often observed that on one side of the kitchen, most often only one room including kitchen, one child may be defecating. Very close to it, another child may be eating food. Private health services. Private medical practice is the fundamental feature of urban health care system. The better off sections like SES 5 and SES 2 nurtures the private medical practice in urban areas due to the callousness and indifferent attitude of the government doctors on the one side and sad state of affairs of the government hospital on the other. Even the poor sections are now utilizing the private health services. Private health centers in the study area are divided into three categories, namely private clinic, private hospital and voluntary hospital. Private hospital provide outpatient and inpatient services and owned by either a single individual or a partnership. In private clinics, the doctor either gives only prescription or medicine from his own dispensary, and voluntary hospital in the study area are the cooperative hospital with outpatients and inpatients facility. It is managed by a board of directors as per the cooperative rules and regulation in practice.
When it comes to your health, it's always good to have all the facts. So let us take a moment to look at the main differences between public and private healthcare in Australia. Public healthcare, which includes Medicare, is provided to all Australians and permanent residents. The public system provides affordable, accessible and high-quality healthcare by providing cover for medical services, such as doctors and specialists consultations, admission to public hospitals, and also subsidises some drugs under the Pharmaceutical Benefits Scheme. If you go to a public hospital as a public patient, you'll be treated free of charge by a doctor appointed by the hospital. However, depending on the treatment you need, you may have to join a waiting list. If you want to avoid public hospital waiting lists, choose your own doctor, be treated at a private hospital, or be covered for additional types of out-of-hospital treatment, you can either pay for this yourself or take out private health insurance. So why do people choose private health insurance? Private health insurance gives you more choices when it comes to your hospital treatment. To start off with, you can choose from a wider range of hospitals. You can choose the doctor you want. You can usually choose when you go to hospital for your procedure. And you can get cover for out-of-hospital extras, such as ambulance, dental care, optical, physiotherapy and other services not covered in the public system. While private health insurance gives you more options for your health care, it also means there may be some extra costs you need to pay yourself. Unlike the public system, you may be charged a gap fee for your doctor's services. If you're scheduled for an admission to hospital, always ask your doctor for more information about their fees. If you're being treated for a condition which isn't fully covered on your policy, you may also have to pay for some or all of your hospital theatre and accommodation fees. If you're planning a hospital admission, always ask your health fund and the hospital about any potential expenses you may have to pay. Finally, if you need to use your hospital cover, your policy may have an excess or co-payment. An excess or co-payment is an amount you agree to pay towards the cost of hospital treatment in exchange for lower premiums. So in a nutshell, private health insurance gives you more choices with your healthcare and can help pay for the things that the public system doesn't.
Reason for moving to private health centers. Though government is incurring crores for running public health centers, many poor people are compelled to go to private health center for treatment. From the sample household in the urban area, it can be seen that 109 households utilize private health services, whereas the government health services was utilized only by 52 households. Complaints against private hospital. The complaints raised against private hospitals or health services were few. As they are charging good amount for the services rendered, it is up to the mark in every sense. But the major complaint on the part of private health service users was that the rate charged by them was abnormal and treatment is expensive. But this complaint had little relevance, as the study made by Aravindan revealed that the cause of an illness episode as outpatient is somewhat same in private and government hospitals in Kerala. Out of 109 respondents in urban sample who used private health services, 10.1% of them complained that it is costly, and in slum 22.6% of 53 respondents also complain about high cost of private health care service. Many upper class and upper middle class respondents inform us that doctors practicing in big hospitals are unnecessarily advising for undergoing MRI scanning, ECG and X-ray etc. for raising hospital resources. Such charges are even too heavy for the lower middle class SES3 and upper middle class household SES2. Utilization of private and government health services. As the healthcare system is covered by both public and private agencies, there exist many households which utilize both public and private health services. In order to get a clear picture of the utilization pattern of government and private health services, only a combined data can provide these results. The very low class and low class household with their meager income may be compelled to go to private health centers for their health needs. They normally go to private health centers when the government health services fails to meet their health needs. Certain upper middle class SES2 and certain lower middle class SES3 households utilize government health services for getting medical benefits. Annual medical expenditure. The utilization of health services and the medical expenditure are highly correlated. The intensity of utilization depends on the capacity of the medical aid seeker to pay for it. But by the linking of medical aid with the expenditure capacity, it could not be possible to judge utilization of health services by the low class and very low class section, because these two classes mainly use freely available public health services. Medical expenditure items of the commodity differ widely from one SES class to another. The expenditure data of the present study reveals that the upper class SES1 and upper middle class SES2 spend good amount for medical care. Their expenditure items include special food, transportation, tests, medicine, consultant fees, etc. Average expenditure on health. In order to see the differences among SES class in the amount of expenditure incurred for health services utilization, the annual average per capita expenditure on health and annual average per capita income was analyzed. Priority of medical expenditure. In order to examine the significance of medical expenditure in the household expenditure, respondents were asked about the priority of different expenditure items in their household budget. The major items of expenditure asked include food, dress items, water, current and telephone, medical, recreation, education, rent and maintenance of house roof. Now in the end, let us summarize what we have learned in this lecture. The private medical sector is vested with certain characteristics. The practitioners are like their counterparts in the public sector, trained in Western type, hospital-based, urban-oriented medical care system. Community health is perhaps the weakest and most neglected part of their curriculum. A license to practice is issued to them soon after their training. Majority of the people used government hospital for inpatient care as they can escape from the huge hospital bill levied by the private hospitals. The analysts of curative care revealed that for outpatient care, only very few are using the government hospitals because they have to borrow entire medicine from private sources. Most of the patients from the government hospital would be discharged as early as possible to avoid the rush in the inpatient ward. But most of them are dissatisfied with the advice and information provided by the hospital authorities for follow-up treatment. The lack of proper checkup of patient due to the callousness of the doctors is causing severe medical problems to the patient and in certain times even death. Lack of medical equipment is also causing severe problem for the patient. The government hospital is meant for the poor and vulnerable in the society. There is no medical equipment properly functioning in most of the hospitals.